Well, thanks, Ellie. It's good to be here still. We've had a fabulous day so far, and I expect it to continue all the way to the end. This session is titled Using Data to Catalyze Change. It was organized and will be moderated by Tim Ginader from CIVHC in Colorado. So I'm going to go ahead and bring Tim on stage and hand it off. Tim, are you ready to go?
Yeah, thank you, Norm. So as Norm mentioned, my name is Tim Ginader. I'm a senior healthcare data analyst at the Center for Improving Value in Healthcare, CIVHC, which is the administrator of the all-payer claims database here in Denver, Colorado. I am really excited to be moderating this session. We have 3 great presentations on the topic using data to catalyze change. So I'll remind everybody listening that you can put questions into the chat, and we will have time for a few questions after each presentation. And then at the end, we will bring back all the presenters to have a discussion and answer any remaining questions. So let's go ahead and get started with the presentations. The first presentation we have is from Rachel Neave and Karishma Chhabria. It is called Investigating Self-Harm Events Using Data Sharing. Rachel and Neave are from the Center for Healthcare Data at the University of Texas.
Today, we will explain how 5 health plans shared data to investigate self-harm events among their beneficiaries and how this is catalyzing change. Investigation into self-harm events came from a project that was requested by the Texas legislature. The legislature requested information from analyzing data from key state health plans to explore drivers and determine ways to reduce costs and improve the quality of health care provided to Texans. The legislature directed the health plans to send data to the UT Houston Center for Healthcare Data to provide the data collection and analysis services. The project has 3 purposes. First was to develop an integrated healthcare information system that can identify potential areas to improve the quality and efficiency of healthcare services provided to Texans. This system is operational and continuously being updated and expanded. Secondly, we're currently conducting analyses to facilitate comparisons of healthcare data within and across all plans to assess population health and how health services are utilized and paid for. Ultimately, this platform is expected to support advanced multi-payer collaborations on projects and programs to improve the value of Texas healthcare. Achievement of this project is that we've successfully collected and aggregated data from 860 sources representing more than 700 million records for approximately 21.3 million people, totaling more than $176 billion in expenditures over 6 fiscal years. The identification of efficiency opportunities using individual and cross-plan data is ongoing. These achievements required overcoming challenges. Now we'll go through some of the big ones. Initially, we collected comparable metrics from 255 different data sources. Now, as I mentioned before, it's up to 860. The plans transferred data via secure file transfer processes. A big challenge was that they sent data sets that all had different ways of providing the data. The data center had to decipher how each data source defined the data and then integrate the data in a way that would ensure the accuracy of cross-plan comparisons. We created data warehouses and secure interactive data portals for plans to analyze their own data, as well as cross-plan data and discover, interpret, and discuss patterns. As interesting findings were discovered, we created graphs and other visual displays of the data, and we added them to the portals. Visuals allow stakeholders to identify trends, outliers, and other indicators of where the target resources are for making improvements. Although challenging, we're endeavoring to capitalize on opportunities to collaborate, partner, and brainstorm about innovative, evidence-based ideas for improvements. One of the bigger challenges has been for the plans to come to consensus on evidence-based recommendations to publish in the biennial report that is our big deliverable. Final challenge is to act on these recommendations to make change. A major project directive is to collaborate on developing and implementing potential value-based strategies. Now that we had all this data aggregated, we wanted to select value-based initiatives that could potentially improve areas of concern for the plans. In order to select topic areas, the group followed the process outlined here. We reviewed value-based metrics from choosing wisely and an initiative of the American Board of Internal Medicine that promotes more conversation around avoiding unnecessary medical treatments and tests. And also from the Leapfrog Group, a not-for-profit watchdog organization that collects, analyzes, and publishes data on the healthcare safety and quality. And then we also reviewed metrics from the 3M potentially preventable events software that the data center uses to categorize and quantify these events. From these reviews, we selected measures that could be assessed with project data, and then we categorized 33 potential measures into the 5 listed categories. We surveyed the plans to assess their interest in each measure. We discussed the survey results with the plans and selected 2 topic areas to focus our efforts. Those were reducing self-harm events from the external or self-injuries category, and the other was improving maternal safety, quality, and equities, such as reducing cesarean sections for low-risk pregnancies from the never events category. Now, Karishma will take over and discuss some findings that we're doing and what we're doing with them.
Thank you, Rachel, for summarizing the project. So as Rachel mentioned, that we selected value-based strategies, and today we'll discuss the self-harm strategy. To select these strategies, we had a 10-step implementation process. And so the first step was to review the plan data, select target issues. That is where we are at right now, where we selected maternal health and the self-harm issues. And so today we'll discuss the self-harm issues. Step 3 to 7 is what we will discuss in the presentation today. So we investigated and gathered data, we shared information, we set measurable goals, selected strategies and metrics, and then we had plans in place to implement for programs. We would collect data, baseline data for these to measure these plans and the progress of these plans. And then lastly, we would collaborate on successes and challenges. So as I mentioned earlier, we would discuss steps 3 through 7, and the methodology for those was to identify data within 2017 and 2020. We identified self-harm events using ICD-10 diagnosis codes. For identifying healthcare encounters, we use the specialty codes. So literature has shown that a patient who does have a self-harm event does see a PCP. And so we looked at 1 year prior to the self-harm event if there were any PCP visits. We also looked at timely follow-up. So we looked at mental health and PCP visits 60 days after the documented self-harm event. So the results of this was that we saw an increasing trend across the plans from 2017 through 2020 for self-harm events. However, we did see a lot of variance amongst these plans. We did note higher rates amongst females, adolescents, and young adults. This next graph shows healthcare encounters and around the provider visits. And so the extreme left cluster that you see, the first cluster is 1 year prior to self-harm event, how many PCP visits occurred, or if there was a PCP visit. The second cluster of graphs you see over there identifies a PCP follow-up time point, so 60 days after a self-harm event. And the last cluster is to identify if there were any mental health professional encounters 60 days after the self-harm event. On an average, we're seeing about 72% of plan enrollees visited a PCP within 1 year prior to the self-harm event, which is a great point of intervention. And then we also identified that only half of those with the self-harm event were seen by a mental health provider 60 days after the event, and even fewer were seen by a PCP. So through all of this work, and as Rachel identified earlier, one of the purposes of this project was to identify efficiencies, and this talk is to highlight the increased use of value-based care. So that's the efficiency that we use to identify approaches for this project. So the significance of these findings was to increase primary care visits, to add opportunities for early identification of mental health issues, and then also support and the pathways to integrate behavioral health care with primary care. And in order to achieve these things, our team is currently developing approaches that will help to increase awareness of current programs with similar goals, provide resources to providers that encourage early intervention and screening risk for at-risk individuals, provide resources for providers that explain how to get reimbursed for timely treatment and follow-up. There are actually CPT codes that are available for timely reimbursement for screening of mental illness. So we are raising awareness on that, not only to the providers, but also to all the stakeholders, such as the plans that are involved. And hopefully with all of this and those programs, just to touch base again, was step 8 in our 10-step implementation program. And through all of this, we are basically trying to catalyze change. And how we did that is we leveraged a multi-payer database for analysis on a population level to implement change. We had early identification and PCP initiatives that were stressed as an important value-based approach. And through that, we have been able to raise awareness for screening of mental illnesses and suicide risk at the PCP visit that would potentially lead to reduced self-harm events. And all of this would hopefully help to identify strategies to increase efficiencies, increase quality of care, and hopefully reduce the healthcare costs. Here is our contact information, and we are here to answer any questions that you may have.
Great. Thank you both for such a wonderful and informative presentation. If anybody out there in the audience has any questions, please go ahead and put them into the chat. So I'll start. Rachel, you talked about the process of getting this portal set up with multiple plans submitting data. What were the biggest challenges you found in getting that process started?
Well, with this many plans, we have multiple plans, multiple years, and over 850 data sources. So the biggest challenge was compiling the data from so many different sources and going through that extraction, transformation, and loading process and linking the data. So linking enrollment data with the pharmacy and medical data, because we have medical data, we have pharmacy enrollment, demographics, administrative claims data, behavioral health, and even some medical, some EMR data. So getting that all linked it's been a big challenge, and I would say that we've been able to match most of it and have only a 1 to 2% linkage error rate.
Would you say that to overcome that challenge, is that more working with the plans to submit data in a more uniform manner, or is it more processing on the back end once you receive the data?
I mean, it's a combination of both. It tends to be a back and forth where we get the data, we see what's what, and then we go back and we get as much resolve with them as we can. I mean, sometimes it does mean them sending more data sets or refreshes, with different columns. I mean, it's been kind of interesting that even the same plan from one year to the next sends it differently, even though they'll just leave off a column or add a column or something like that, and we need to. But those are more of the easier resolvable issues. But yeah, there's always something, and there's a fair amount of back and forth with the plans.
Sure. Karishma, you showed a slide that showed an increasing trend in self-harm events over the years, but there was a large variance in the plans. Do you have an idea of what's behind that large variance?
Yes, great question. And unfortunately, we cannot reveal identify the plans, and that's why we've called them plans A, B, C, D, E in the presentation. And so, trying to keep that in mind, I'm going to answer your question a little vaguely, so I hope I can convey my information. We did identify reasons why there were discrepancies, and it was expected in a way that when you would expect, SES, demographic variables, to have that kind of impact. So the population that was served by the plan, we would expect high or low, depending on, let's say, education information in that plan, the enrollees, how educated they were, whether this was a private insurance versus this was a, uninsured population, for example. So I cannot identify the plans, unfortunately, but there were definitely very valid reasons why we're seeing this variation. However, we used all of this data, and even though there are great variances across the plans, all of these plans were interested in the self-harm initiative, and they were interested in reducing the costs and reducing the rates of suicidal behaviors amongst the population, in their population. And so we used their data, and even though they did not have very high rates, they definitely were interested because they have identified that reducing suicidal behaviors has become, especially since COVID, it has become a need within the US system. And so keeping that in mind, we all, strive forward to identify strategies to reduce these rates. I hope I answered your question. I'm sorry, couldn't identify the plans, but different vulnerabilities, different, social demographic variables, SES, education levels, and that we kind of expected that.
Sure, great. Yeah, thank you both. We're going to move on to our second presentation. This presentation is from Emily Sim, who is the Senior Director of Analytics at Comagine Health. And the presentation is entitled, A New Use of Claims Data, Case Management to Improve Health Outcomes.
Good afternoon. Let's start with a few questions. Where would you predict someone is likely to go for their healthcare needs when they have a history of myocardial infarction and heart failure, they don't have a primary care physician or a referral to a specialist, and they have the added difficulties of experiencing problems with securing housing and are also struggling with an opioid addiction? Or how about an individual with a history of obesity, limited mobility, and chronic pain, who's also suffering from a serious mental health condition and doesn't have a trusting relationship with a primary care provider? Where are they likely to go for their health care needs? Well, the answer, of course, is the emergency department. And in emergency departments across the country, providers are struggling to meet the many needs of these patients, who often wait until they are seriously ill to receive help. This was the situation facing one of Comagine Health's clients, a state Medicaid agency who was seeing overutilization of the emergency department for a subset of Medicaid members with complex healthcare needs. Not only is this expensive for Medicaid agencies, but it's expensive for the Medicaid members themselves in terms of quality of life, which is much lower than it would be if their healthcare needs were being met more holistically. Looking at this subset of Medicaid members, we could see that they often have complex healthcare needs. They have issues of behavioral health or substance misuse. Their healthcare needs are often exacerbated by social determinants of health, such as lack of housing or transportation. So Comagine Health designed and implemented a program to provide in-person case management services with two goals. One, to reduce emergency department and hospital utilization while improving, our second goal, member health outcomes. So here's a quick case management explainer. Case management helps people with catastrophic or complex chronic conditions receive the services and support necessary to manage their healthcare needs. Comagine Health's case managers work closely with patients, families, providers, and payers to develop, implement, and monitor personalized, holistic care plans. Our services help patients and families navigate the healthcare system and offer solutions to barriers and challenges they encounter. Patients have improved health outcomes and an increased understanding of their unique health conditions. Now, in-person case management is exactly that. It's in person, as opposed to being over the telephone. In-person was chosen for this population because historically, members experiencing this many social determinants of health factors have been difficult to contact and maintain contact with over the phone. Our plan was to partner case management strategies with claims analysis to initiate, monitor, and evaluate case management services and outcomes. So to run such a program, eligible Medicaid members need to be identified. We use two methods. The first is facilities and providers could refer individuals they thought would be good candidates. The second method is that we would ID individuals using claims data. Then these two lists of Medicaid members were given to the case managers for a final determination if they were eligible according to the program's criteria. So let's dive into how the analytics team used claims data to identify eligible Medicaid members for this program, and then some of the additional analyses that they did with the claims data. So we decided to use the CMS HHS HCC risk adjustment model to predict high-risk users of the emergency department. As part of the Patient Protection and Affordable Care Act of 2014, insurance underwriters were no longer allowed to exclude individuals or adjust pricing to account for previous conditions. So to protect participating health plans from adverse patient selection or keep them from cherry picking that could undermine the program, CMS created a risk adjustment model developed on commercial claims data. The result was the Health and Human Services Hierarchical Conditions Categories Risk Adjustment Model, HHS HCC. One of our analysts had used this in individual health insurance space and had decided to give it a try to identify individuals who are high risk for less appropriate ED utilization. Using available specifications, he coded the model on the Medicaid claims data. Now, this model hasn't been studied to see if it correlates with inappropriate emergency department use, but rather the model indicates severity of conditions and overall healthcare system use, and we are using it as a proxy. Of course, this is just a method for identifying those who might be eligible, and the final determination is not made from claims, but is made by a case manager. So to select members using claims data, we were able to isolate the high ED users, collect diagnosis information, and calculate a risk score based on this risk adjustment model to identify those that we thought would be the best fit for our case management services, solely looking at the claims data. Now, additional to using claims to identify prospective enrollees in the program, we also use claims in the following ways. We normalized claim trends, allowing a direct comparison of claims experience prior to enrollment to claims experience post-enrollment on a per member per month basis. We looked at individual claims experience tracking, including visualizations of emergency department and hospital usage prior to enrollment, during enrollment, and after disenrollment for members on an individual level. We did claim lag studies, allowing us to estimate the amount of claims that have been incurred, but not yet reported, and factors into how long after a reported time period we need to wait to see an acceptable level of completeness. We also did a high emergency department utilizer study to see how well we were targeting our intended population of high emergency department utilizers through member selection and enrollment. Additionally, we did risk scoring regression analysis to evaluate the accuracy by which risk scores could predict future claims, and the answer was not much. And we looked at the minimum claim study to determine what base level of claim cost would be needed to achieve an effective savings. However, this study was not used to restrict enrollment in the program. As revealed by the risk scoring regression analysis, the risk score is a useful tool in determining severity of current conditions, but does not sufficiently predict either the claims volumes incurred in the following year or the change in claims volumes from one year to the next. So it was good at identifying individuals, but was not predictive. Another thing that we learned is that engagement rate and program adherence poses challenges. So the nature of the target population poses specific challenges to program evaluation, with many members too difficult to connect with, refusing service, or discontinuing services before goals are met. And when conducting analyses, it's always important to remember that members can gain or lose eligibility from month to month, which is why most of the analysis is done on a per member per month basis. So some of the things that we've looked at doing in the future is we've thought about looking at preventable emergency department visits. There are good measures out there now for that. And so we've thought about coding up those measures and using it on the Medicaid claims data. And then we could further refine our selection criteria to identify the members who have significant claims within the preventable category. And another thing that we are looking at doing is using propensity scoring and propensity matching and scoring to be able to look at a better return on investment measure, being able to compare individuals to other individuals that are as like them as possible, with the exception that one is enrolled in their program and the other is not. And we're just beginning to look at that. Thank you. That's just an overview of the ways we've been able to use claims with our case management services, and I welcome any questions.
Great, thank you for that really interesting and informative presentation. I found it interesting that you mentioned that you used a regression analysis on the risk scores to predict future claims, and you said there was not much of an association. What do you think is why do you think there was not an association there?
That's a great question, and that was originally surprising to me. So I'm not the analyst who did this primary work, and when I first talked to this analyst about that, I was surprised too. Like, why is this not predictive? And it turns out that he actually wasn't terribly surprised that it wasn't predictive for a couple of reasons. One reason is that he's actually already seen studies in the actuarial space that show that it's not predictive in that way. So he wasn't surprised when it wasn't predictive with our data. But I think that maybe the thing that could explain why it's not predictive is that claims are a very small part of why. I mean, claims are really good at, say, describing like the severity of an illness at a snapshot in time. But what they're not good at showing us are all the other factors around why someone might be choosing the emergency department to get their care. So, we're missing all that social determinants of health data. And if we had all of that experiential data that would be around those claims data, then I think we could build a much better predictive model.
You also mentioned that this population is difficult for this case management program. Do you think that there is a way to increase buy-in to the program, or does this type of case management just rely on active patient participation?
So I think yes and yes. So this type of work does require active patient participation. Patients do need to be fully engaged to get the full benefit of being involved in case management. And we did do things to actually increase that buy-in. So not having it be done over the phone. A lot of case management is done over the phone or done over video, using technology. And for this population, we knew that we just wouldn't be able to get the number of patients that we wanted to be able to impact that way. So by having it be in person, so we're actually going to these people to have them be a part of the program, that did increase buy-in. But it is a question that our nurses are always asking. How can we be better at getting buy-in? How can we increase how long someone stays in the program? How do we increase that work? Because that's a primary goal for our nurses.
Mm-hmm. Great, thank you. Let's go ahead and move on to our third presentation. Our third presenter is Joydeep Sarkar, who is the Chief Analytics Officer at Holmusk. And his presentation is on natural language processing and machine learning models to accelerate generation and application of real-world evidence in behavioral health.
Good morning, everyone, and thank you for giving me a chance to speak at this conference. My name is Joydeep. I'm the Chief Analytics Officer of Holmusk, and today I'm here to really talk about how we can use natural language processing and machine learning models to help generate real-world insights and evidence for behavioral health. Before I get into how we're doing this, maybe I can spend a few seconds talking about what is really the scale of the problem. As we all understand that behavioral health, even to this day, in the real world practice, is still very subjective in nature. There's lack of quantitative scales, psychometric scales that are used in the real world just because they're too cumbersome. The vocabulary used by different clinicians to describe patient symptoms is not as standardized as maybe metabolic diseases. It's not as easy to come up with a corpus or a set of keywords that tend to work well for these kinds of systems. And when you read the unstructured clinicians' notes, you realize that providing that it requires significant amount of context and domain expertise to really comprehend what is really going on. As a result, it's been difficult to develop very good models for clinical notes, clinicians' notes for behavioral health. Holmusk is trying to do that right now. We'll speak some of our success stories on that front, and that's what this whole presentation is about. Before I get into that, I wanted to give you a brief overview of where things are in the world of NLP for behavioral health. Throughout the years, the use of deep learning has gone up significantly, but as you will see that even to this day, and this is a paper coming out this year, only 6% of the work that has been published uses actual EHR data. Unstructured data, which means a lot of it is really still more social media and other sources of data. That's one. Only 70% really uses transformer-based architectures, which is what we're going to talk about. And a lot of the applications are still more directed towards identification or detection of mental illness rather than really getting into more clinical evidence generation, understanding of clinical care, those kinds of things. We've been working in this field for a while. In the past, we've worked with semi-structured data in some other EHRs where the form of the clinical note was more categorized, was more small phrases. And for those kinds of things, you can get away with using things like LSTM models, which are simpler to develop, simpler to process. However, what we know, and we've published this work, however, what we know is that you cannot use these kinds of models when it comes to larger, completely unstructured clinical notes. And that's why we have moved forward to develop a new way of doing this. So what is that about? What you realize is that here we have a sort of our method broken down into steps. The first step is obviously collecting the right clinical note that we're talking about. It's being developed, been written by a clinician, which is tied to a patient to a particular visit. There's a part about processing that, breaking it up into different sentences and processing the sentences one by one through the NLP model, then aggregating the insights across the different sentences to then create a note level insight or generation or inference from the NLP model. But let's talk maybe briefly about what is the NLP model. The way we have developed the NLP model is that it has two pairs. We're not the first person to do this. This is a well-established architecture by many others. But what we have is a NLP1 that we call it, which is a bird style model that we have customized ourselves, and then a series of classifiers on top of it, which are specific to the type of information that we're extracting from the model. And we'll talk about some of those examples in a minute. So to get to the actual work, we've had to develop a full-fledged sort of machine learning or NLP pipeline, as you may say. We have had to develop our own annotation UI, annotation tool for the annotators to actually go through the notes, annotate and give us good labeled data. A lot of training and iteration there to produce a really good, reliable data. And this takes quite a bit of effort to kind of go through and develop. But also on the training and evaluation part, the way we have looked at the model is it's in three phases. The first phase of the model is really around pre-training the model, in the sense that how do we teach the model how to understand the linguistic patterns that are present in the clinical notes of that are generated by the behavioral health. The second phase of the model training is around comprehension, which is telling the model which are the sentences that actually should be similar versus which are the sentences which are different from each other, and trying to sort of semantically separate out those sentences. This is called triple class. And the last phase of the training and validation is around classification. This is when you convert all of this into the presence or absence of specific features within the model, within the data. And you can see all they have different ways of training and validating. We started off by just proving to ourselves whether this actually helps. And as a part of that, what we did was use two separate models, both of it published with a specific set of behavioral health data, and then use one of those models and really pre-train and fine-tune for a specific set of labels and show that actually this makes a huge difference in terms of being able to train the model to the linguistic patterns and the context of behavioral health. Makes a huge difference on whether the output is going to be significant or not. We took this example and applied it to a more clinically relevant example where we were going to spit out, tease out details about different types of MDD, major depressive disorder patients, anhedonia, suicide ideation, with or without plan. And you can see we ended up with those three labels in the end. And what we can now show is that with a decent sample size, we can actually produce very good results when it comes to anhedonia and suicide ideation with intent. The without intent or plan still has more work to be done. It's still 75% PPV, but I think we want to get a little more. And on the 98% PPV for anhedonia, I think it's overtraining. So we want to pull back and see what we can do to sort of make it more robust. But this is where things are. Why do we care about this? Is a big question. And I'll skip this slide, and this is important, which is, this is where the world of psychiatry is really going, which is going from the MDD or major depressive disorder as being a diagnosis group versus going at subtypes of patients, let's say comparing the effectiveness, real world effectiveness of actual drugs on specific subtypes of MDD. So let's say MDD with anhedonia versus without anhedonia. And here's an example of what can be done with that. But the real question out of all of this is where are we going from here, which is what's most exciting to all of us. There are three places that we're really working on. One place is how do we produce more validation of the model? Today, we are validating it simply by looking at the notes. What we want to do is validate against even a higher bar, which is we have data where the patients have recorded more patient-reported outcomes like PHQ-9, which would have the same data that we are producing, as well as more psychometric scales like QIDS. So can we, through NLP models, produce the same level of accuracy as a PHQ-9 or QIDS would do? Because that raises the bar, obviously. That's one. Two, how do we make our models more robust, more generalizable by adding different types of data from different types of EHRs, from different health systems, and really produce a model that is more generalizable across EHRs, across health systems. And the third phase is right now, as you can see, the examples we showed are mostly around major depressive disorder. How do we take that and then expand that to other disease areas? So let's say ADHD, schizophrenia, PTSD, bipolar disorder, there's a borderline personality disorder, there's so many. And how do we then anxiety disorder, but also slowly expand the type of information we're also expanding. Today, I showed you examples of just, let's say, symptoms. How do we go from there to more broader examples like side effects, adverse effects, and the others. But that's all we have time for today. Thank you so much for your time. I think I'll be very excited to get more questions and comments about how we can move this forward. Thank you and have a good day.
Great. Thank you so much for that presentation, Joydeep.
Good afternoon.
Good afternoon. What would you say is the biggest challenge you had in establishing this model or getting this project set up?
Oh God. Determining the right, the problem with doing this kind of NLP that we've never seen anything like this being done in the clinical domain with, we're getting more questions, okay. Getting the right constructs, what can be reliably extracted from clinical notes, and not being confused because it often gets noted like, oh, this was from the past, this is now. So how do you actually know what is the truth? Just establishing ground truth when you read a note is hard enough. If you don't know that, you can't teach your model anything. So that's the first challenge. And then really knowing, did I teach the model right thing? That's I'm an old school guy in some ways, but believe in first principles, not just the brute force way. So did the model learn what I wanted it to learn? That is by far the hardest thing to try and achieve. So I think we have done well for certain cases. I think there's still more work to be done. It's an open area.
How do you see this type of machine learning and natural language processing changing the way behavioral health is diagnosed or treated?
Yeah. So the biggest challenge, if you go into the world of behavioral health, is that clinicians really do not have the data to be able to say what works and what doesn't in what kinds of patients. Why? Because a large percentage of the data is in unstructured format. Now, we're actually starting to get to the point that we have structured information at every visit in a longitudinal way for every patient. And when you get to a large number of those, like we have like 1.4 million patients now, you start trying to answer those questions. Well, when do certain things work, when they don't? What are the predictors of the patient's risk of a exacerbation of their disease? Can we do those things? And we start implementing them both from a drug development and targeting standpoint, but also from a care standpoint. The first step is getting the data. If you don't have the right data, you can never get the answers. And so that's where we are right now.
Great, thank you. Yeah, let's go ahead and bring everybody back on.
I think that last question is for me from Sylvia.
Sure, yeah, we can start with that one.
So actually, Sylvia, the answer is we do, and we have more work to be done because when we sample the data for the purposes of training and validation, the training sample has to be very carefully generated such that there is no bias of these demographic factors. We have sometimes these biases in the data, so we have to undersample, oversample, do a relatively complicated sampling exercise so we do not have that kind of bias. We are very careful because there have been lots of models in the past where we know that these kinds of things have creeped in. The cultural components are dangerous, and we have not yet addressed that. We know that even things like education level of patients make a big difference of their ability to communicate and how that actually gets documented. We have not seen like primary language being a factor yet. We have not noticed it. Doesn't mean the signal doesn't exist. So we keep an eye for those as we're building the models.
Great. Welcome back, everybody. We have a few audience questions. If there are more, please go ahead and add them to the chat function. We'll ask them throughout here. I believe we have one from Tom Bell for the first presentation, Karishma and Rachel. Were social and economic data reported by person, or did you use aggregate data like zip code or statistics on income or such?
Thank you, Tom, for the question. So although we did have zip code level information across the plans on the individual level, we did not use that information because the goal of this project was to identify ways that we could reduce suicidal behavior, self-harm events in each of the plans. And so we were not interested specifically looking at why variations existed across the plans or amongst the plans. We knew that going in, depending on the population that the plan served, that there would be differences, but we did not really dive into identifying why those variations are there. The literature definitely has a lot of information on that, and if I could have identified the plants, it would have been very obvious to you as to why those variations exist. However, if we are interested in, or if you are interested in looking at variations across, why variations exist across the plans, yes, we could use the zip code level information and merge that with SDOH data that's available. We could use the social vulnerability index and such to identify reasons why there are variances amongst these incidence rates.
So this session is entitled Using Data to Catalyze Change. So I think it'd be interesting for each of you to answer, what are the biggest ways that you see your areas of research and discovery changing healthcare, and maybe talk about some of the biggest changes you've already seen?
I'll say something that's going to be really funny. But one of our projects that we are working on is with UT Houston. And the goal is to use our NLP and use some predictive models to deliver more accurate predictive models for UTHealth, for specifically, let's say, identifying patients who have a risk of a violence or bad behavior when they're admitted, and how do you actually identify them early and take preventive measures. So I think we are starting to collaborate and work together because the need is very acute. But just to give you an example, the kinds of applications we can easily see in the near future.
Karishma, Rachel, or Emily, do you have any thoughts about that?
Could you just restate the question real quick?
Sure. So since this session is titled Using Data to Catalyze Change, what are the biggest ways you've seen your research or discoveries changing healthcare in the future, or the biggest ways you've seen it already happening?
I definitely think that with our data, I mean, we just published our second biennial report, which is the first report that has results in it and some outcomes and some recommendations. And so that is exciting that that's out there, and we're on the precipice now of actually using this data that we've been collecting and analyzing and talking about now for 3 years to try and affect some evidence-based change based on these outcomes. And so that's happening now. I mean, it's a it's a young project, so I can't really speak to how things have already gotten changed because of it. I mean, one thing I would say is that the plans that we're working with in the beginning, there was hesitancy sharing data, and that since we've been working together for the last few years, establishing these collaborations, establishing trust, and working together to make sure that, when there's less favorable results for any one given plan, that we are sensitive to that, and we're cautious about how we present things, that kind of stuff, that there's a lot less hesitancy now, and there's a lot, it's easier to work together. So we're very excited to have results and being able to put some actions in place. So, and which is what's happening now. So I think that we'll be actually starting to do some intervention type things based on this in the next few months. We're just getting started.
I'll just add to that, Rachel, that is a great answer to the question. But as Rachel said, we are moving towards catalyzing change through all of these findings. There was a little resistance from the plans with who did not have favorable results, but the idea behind it being that we're all going to come together and figure out the best strategy to reduce these rates, and not just to make plan X look better than plan Y. That's, not the goal of the project. And so keeping that in mind, we have been able to move forward, but we're also considering each plan's needs based on their population, right? So we are meeting with them one-on-one, and we are bringing in experts from the field to help. So now that we've identified, that we should be doing more screening at the PCP level for mental illness to reduce the self-harm behaviors, how is that going to be possible? Because at the PCP level, the providers are already tapped out. They're already doing so much, but it is very crucial, right, to screen for the mental illness and not just refer them to psychologists and psychiatrists who have a long waiting time. And so we are bringing in experts who are helping, talk about and bring light on the logistics of integrating mental health and behavioral health with PCP visits, and how we can address that through the plans, right? So what can the plans do to help facilitate that? So we are, talking with each of the plans to gather information as to what is a feasible yet impactful intervention that we can carry out for all the plans across. And so that, I think that is, amazing how we're all coming together to move this forward and hopefully reduce suicidal rates in the population.
And I would just add, for us, traditionally case management. So case management is very individual, and it's not like a lot of care management overall is becoming very automated, but there's not a lot of automation that can be done on the individual basis when you're working with someone and their unique needs and their unique situation. But what we are finding, though, is new ways to get people into the case management pipeline and to get them the help that they need. So, referrals would have been the old way of that people could get into a program like our case management program. But by using the claims data, that is a sense of automating that referral process so that then we can find those patients who otherwise may not have made it into the program and then can be helped.
Thanks for those answers. In the final few minutes that we have, I think it would be interesting for anybody and everybody to talk about when we're thinking about using data to catalyze change, it's important to have data that is accurate and reliable. So what kind of steps or processes have you or your organizations established to make sure that the data you have is reliable and accurate?
Well, I mean, I would say that that's one of the most challenging parts of dealing with data, this level of data, this amounts of data. At our organization, that there's fortunately a phenomenal team of analysts that go through a very labor-intensive process of getting that data from the plans into the data warehouses, and that is a lengthy process and I think that talking to different other organizations and learning best practices and trying to implement automated processes for some of the bigger processes. I mean, automating that, I think that that's helpful, but yeah, it's very challenging.
Let's go. Looks like we have another audience question that came in from Brenda Jenny. It says, for Joydeep, can you explain a little more about how the behavioral health clinician notes data that are used in the natural language processing model are different from or enhance diagnosis code-based information in claims data?
So let's take an easy example. The best you can get, let's say with ICD-10 for MDD, is you look at the point X and the demarcation of that, which tells you that the patient is a single event or multiple event, and whether it's recurring, that kind. But you rarely see any further subsegmentation of those patients. Let's say, does this patient have sleep problems? Does this patient have anhedonia? Does this patient have anxious depression? Or does this patient have psychotic depression? You start looking at many, many different layers of the different types of just MDD itself, and which symptoms do the patients present themselves. And as you treat them, which ones are getting better? Which ones are not getting better? Which ones are getting worse? You don't have that in a diagnosis information. Ideally, you would want scales to be administered, PROs to be administered, but we know that other than PHQ-9, which I've seen a lot being done nowadays, it's very rare. So how do you actually get that level of granular information for patients at every visit? Because the clinicians are seeing them, and from what we can tell, they ask, they document, it's there. Now it's a question of getting it out of there into a structured format, which you can then analyze for answering any number of questions.
Looks like we have another question for you, Joydeep, from Robert Kilgrove.
Yes. The short answer is we absolutely have to. Oh God, look, SE. There's so many. We have a very long list of such side effects. But keep in mind that the shorthand notations are absolutely needed. But it's also in the context. It's very rarely that we're not looking for keywords within the text, but we have to understand what these different shorthands that are being used by clinicians. And keep in mind what we have seen, the shorthands evolve with time. They're not one shorthand that you can do. So you have to sample over time and see that different clinicians over time use different kinds of shorthands. And that is a library that we have had to build. If I can go back to the question you had asked about quality and how do we talk about data accuracy.
Absolutely.
I think for us, there's several things that we do on our front. I'm not even talking about necessarily NLP, just in general, that we triangulate information from as many places as possible. So like billing versus diagnosis table versus any other place. Generally, you will see that EHRs often enough have the same information in more than one place. A timestamp is present in more than one place. Medication is prescribed, information present in more than one place. So how do you triangulate that information? It's a very common thing to see that if you look at age over time, sometimes patient ages just get wrongly entered, and at one point it became 150. You're like, that's possibly not correct. So we see this all the time, and we have to correct for that. So a lot of quality control in looking at you could say longitudinal view of the patients to look at if the data thread is something we can stand behind. And if we have too many challenges, we take those patients out. It's a lot of work.
Great. Well, thank you all
for... If the data is not correct, you can't trust anything that comes out of it.
Very true. Thank you all for a wonderful session and a great discussion.